everyone, and welcome to the integration of HIV services into comprehensive social services for most vulnerable children and youth webinar. My name is Mary Gatama. I'm the program manager at Railway Children Africa, and we're really excited that you were able to join us for this webinar and for us to share our work. And also we have in the panel, we have very good presenters that are going to also share their work, and hopefully you learn from what they are doing. Just some housekeeping first. Your video and sound are turned off. You're able to communicate and comment and ask questions through the two functions. Comment in the chat. You can make comments in the chat box and questions in the Q&A box. We have interpretation from English to Kiswahili for this webinar if you'd prefer to listen in Kiswahili. So at the bottom of your screen, you'll see there's a globe there, so you can tune into Swahili if you need Swahili translation. I'm also excited to introduce our moderator for this session. That is Dr. Edward Moshi. He's working for PAC Tanzania as a technical services coordinator, bi-direction referral and leakage. And he'll be the one hosting this, moderating this session for us, and also introducing the speakers for this webinar. So thank you everyone, and happy that you were able to join us for this session. Welcome, Edward.
Okay, thank you, Mary. Thank you, Mary. Hello, everyone. Welcome again to this webinar of integration of HIV services into comprehensive social services for most vulnerable children and youth. As you know, since the beginning of HIV epidemic, children and youth have been considered socially and physically vulnerable to HIV infection, given the risk of HIV transmission during pregnancy, childbirth, also due to sexual abuse, limited access to use of reproductive and health services, and also poverty and stable households, of which these have been contributing to rise of HIV infections among children and adolescents. And this has also been more profound, affecting children who are in the category that we call the most vulnerable children. According to UNAIDS report, there are estimated around 1.2 to 2.2 million children and youth who are living with HIV globally. And in order to be able to curtail these new infections, we need to have mechanisms that will be able to address the issues that are affecting these children and also youth who are also living in vulnerable environment. So if we look in terms of prevalence, while the prevalence of HIV in vulnerable children is higher than those who are living in hard to reach areas, like in mining areas, or the children who are living and working on the street. But overall data shows that the longer these children are living in the streets or in mining areas that are risky to them, the more they are prone to increasing their HIV risk. Therefore, in order to end these new infections among children and youth, we need to have HIV integration services being integrated into comprehensive social services that are being delivered to most vulnerable children in different societies. So for today, in our webinar, we'll have two speakers. I would like to introduce our first speaker, who will be taking us through the first session, Dr. Charles Makoko, who is working with PAC Tanzania, is HIV Integration Advisor for the Kizazi Kipya project. He's an experienced clinician and has been working to support various organizations to attain the UNAIDS 95 and 95 goals for almost 7 years now. So without further ado, I would like to welcome Dr. Charles to take us through the first presentation. And as we'll be presenting, I would like every one of us to take time and note if you have anything that you want to ask. We'll have a question and answer session after the two presentation has been conducted. Karibu sana, Dr. Charles.
Thank you, Dr. Edward. Good morning, good afternoon, and good evening. As I've been introduced, I'm Dr. Charles Makoko, HIV Integration Advisor working with USAID Kizazi Kipya project and APACT, and I'll be taking you through the presentation on differentiated HIV package of services for the children and youth living and working in the streets. My presentation will have the outlined areas. We'll have a slide on the background, key HIV intervention, obviously HIV start indicator. We'll look at the viral load suppression updates, HIV prevalence, and also the lessons we have learned through implementation of the Kizazi Kipya project. So a bit of introduction, the integration of HIV services for children and youth living and working on the streets. As we know, the children and youth living and working in the streets is one of the most excluded and hardest to reach groups of vulnerable children due to their living situation and their mobile nature. Children and youth living and working in the streets are exposed to major health risks and problems such as violence, sexual abuse, mental health issues, issues around substance abuse, and they have an increased risk of sexual transmitted infection, including HIV. Working with Railway Children and USAID Kizazi Kipya project, we have strategies that we use in identification of children and youth who are living and working in the street. One, children and youth living and working in the street are identified through night and day street outreach activities, which are conducted by Railway Children. We also identify the children through drop-in centers, also through mapping of hotspots where children and youth who are living and working the street are found, such as in marketplaces, for them to be enrolled into the project. We also work with local government leaders to target girls who are working with food vendors on the streets. Also, we use, or with the support of girls already enrolled in the program, would they help to identify and refer girls in similar situation to the project. We also utilize the youth association groups to help identify their peers so that they can be enrolled into the project. So the key HIV-related interventions and supported under the children and youth living and working in the streets. One is HIV risk assessment at enrollment and quarterly assessment to monitor and provide support for HIV-related services. Another is provision of nutritional assessment to identify the nutritional status and HIV testing services referrals and provide them the HIV testing referrals as appropriate. Also HIV data extraction to monitor adherence and viral load suppression for those who are HIV positive. We provide HIV education and awareness sessions, as well as accompanying of the children to HIV testing services for those who are at risk or have not had a HIV test. We also support ART adherence to address barriers related to ART uptake. Under the Kizazi Kipya project, we support the beneficiaries through the 95-95-95 UN goals. Under the first 95, we conduct HIV risk screening for the beneficiary enrolled in the project. Also, we refer and escort all of the beneficiary to HIV testing services facilities. We conduct HIV screening for the beneficiaries' families during family reunification, and also refer and where possible escort families to facility-based HTC services through the bi-directional referral system. We also coordinate with care and treatment implementing partners to conduct mobile testing during street outreach activities. Under the second 95, we ensure coordination and accompany the beneficiary to CTC, those who are identified HIV positive, so that they can be initiated on ART. We also provide the beneficiary who have food insecurity with nutritional support and link them to other service providers to ensure that they are initiated treatment. Also, we support children and youth living with HIV to have a secure place to store ARV through example, the drop-in center, residential facilities, or personal contacts. We also monitor incomplete beneficiary referral to care and treatment and provide the necessary support for them to access the services. And where necessary, we link with health and HIV officers and case management coordinators. We link them to families to initiate, for the families to initiate HIV treatment. Under the third 95, we provide ART adherence support and counseling at the residential facilities as needed. We also provide CSO staff are trained in ART adherence and also provide the support on barriers of adherence at through home visits to the caregivers. We will also refer and link HIV positive beneficiaries and their caregivers to people living with HIV support groups. And also, when necessary, we link the health and HIV officers and case management coordinators to families for treatment and adherence. This slide show our performance in the indicator which measures access of HIV services, OVC HIV stat. As of FY21 Q3, looking at the last bar, which shows the number of beneficiaries that are supported, among the 3,604 beneficiaries who are children and youth living and working in the streets, we have 3,364 have been reported negative. We have tested 123 did not require a HIV tests. We had 60 of them with unknown HIV status, and we are supporting, we have 55 beneficiaries who are reported positive. So 98.3% of the beneficiaries we are supporting know their HIV status. So looking further at those who are HIV positive, the 55 of them, the last bar graph shows the disaggregation of the beneficiaries in terms of those who are on ART, who are 54, and one of the beneficiary was not on ART as of FY21 Q3, but has been, currently the beneficiaries has been linked to ART services. Among those who had HIV unknown status, 62 of them were not assessed, and this was because they had been enrolled within the same quarter of this report, but currently they have been identified and linked to clinical IPs and community IPs who are providing testing services for HIV testing. So as I also mentioned, we also monitor the viral load status of our beneficiaries through working with the National AIDS Control Program. We are able to access a viral load data of a beneficiary, while also ensuring confidentiality of the beneficiaries that we serve. So out of the 55 beneficiaries that we are supporting currently, we have been able to identify 20 of them in the CTC3 database. And out of those who in the CTC3 database, we have 94% of them, which is 18, having a viral load test. And with a viral suppression of 94%. So efforts are continuing to make sure that we link and match all the beneficiaries that we are supporting through the national database, so that we can really monitor and identify beneficiaries who are in need of viral load monitoring on viral load results. So this slide shows the HIV prevalence across different groups in Kizazi Kipya project. You'll see that the OVC general, we have 12.7% of our beneficiaries being HIV positive. Among those who are in beneficiary who are in mining, we have 5.2% of them who are HIV positive. Among OVC of female sex workers, 4.1% are HIV positive. And among those who are among children and youth living and working in the streets, we have 1.5% of the beneficiary being HIV positive. The Kizazi Kipya project also did a descriptive analysis on HIV prevalence rate among children and youth living and working in the streets. This was an analysis which was done for beneficiaries in 5 regions of Dar es Salaam, Mwanza, Arusha, Iringa, Dodoma, and Mbeya. The study was conducted in 2019, but one of the findings that we had was that of the children and youth living and working in the street that were tested HIV positive, we found that 83% had been on the street for over 1 year and above. And so we saw that time spent on the street has an increase, seems to be an increase in the risk for HIV. So the efforts around making sure that these beneficiaries are identified and reunited to their families is important to reduce this risk. So the lesson learned through implementation of the Kizazi Kipya project. One is accompanying of the beneficiary to HTS services contribute to effective and complete HIV referral. We also have drop-in center facilities which contribute to ART adherence, making sure that the beneficiaries really adhere to their ARV medication. We also learned that the use of food vendors that are known to the beneficiary not only contribute to their nutritional needs, but also contribute to adherence through reminding of the beneficiaries to take their ART. And also HIV intervention for children and youth living and working in the street needs to take into consideration the mobile nature of street-connected children to ensure an increased uptake of the services. Lesson learned on access to HIV testing and ART. One is on escorted referral to CTC contribute to high uptake of services such as HIV testing services, ART initiation, adherence, as well as disclosure. We also learned that availability of fit families to support caregivers will, with accommodation needs for high volume CTC services. We also learned that drop-in centers facilities contribute to ART adherence among HIV positive CLWS. And also project staff have a role to support ART uptake in this to these beneficiaries. We also, the use of food vendors that are known to the children not only contribute to their nutritional needs, but also contribute to adherence, as I've mentioned this in the previous slide. And also HIV intervention needs to be tailored to the mobile nature of the beneficiaries who are living and working in the streets. So these are areas which will need improvement. So thank you for your time, and back to you, Edward.
Thank you, Dr. Makoko, for the presentation. I would like to welcome our second speaker, who is Stephanie Stavensky from Johns Hopkins University, Bloomberg School of Public Health. Stephanie, she's an evidence-based mental health specialist who has been working for over 10 years in assessment and developing of evidence-based mental health treatment and assessment in middle and income countries. She's trauma-focused CBT trainer, and also she's a co-developer of SETA and SETA Brief intervention for substance abuse. Welcome, Stephanie, to take us through your presentation.
Hello, everyone. Thank you so much for joining today, and a big thank you to Railway Children and USAID for hosting this event and asking us to speak. My name is Stephanie, and I'm part of the Applied Mental Health Research Group at Johns Hopkins University. I'm going to be talking today about integrating mental health services into HIV services for OVC and street youth. So just to start, when we think about integrating mental health and psychosocial services into programs for children and youth at risk or affected by HIV, we really need to think about two different ways of providing services. One is preventative care, and the other is for treatment. From a prevention perspective, we know that OVC experience high levels of stress and trauma. And from Dr. Makoko's presentation, those are exactly the sorts of events that he was talking about: child sexual abuse, the living on the street, the number of different traumas that children face. And so when we think about those, they also include HIV stigma, abuse, poverty, reduced social support, reduced access to medical treatment. And these problems can contribute to risky sexual behaviors, as well as increased substance use and mental health problems. So addressing trauma and stressors by providing life skills and coping to manage these challenging situations is critical for HIV prevention. From a treatment standpoint, we also know that common mental health problems for people living with HIV are common, and they're associated with very poor treatment outcomes, such as adherence to treatment, viral suppression, and symptom progression. So at the same time, we know for children that there is a huge gap in mental health services. So why mental health services in HIV programs? There are many benefits of integrating mental health screening and treatment into HIV care. This includes reduced risky behaviors, improved adherence to treatment, improved linkages to and retention, reduced viral loads, and reduction in HIV transmission. So a little bit of background from my work. I was lucky enough to be able to live in Zambia for 10 years as part of my career. And over the past 15 years, I was able to work with children and families in over 17 countries. And in the beginning of my career, I was part of several trials that we did in Zambia and Cambodia and DRC, working with trauma-focused cognitive behavioral therapy and cognitive processing therapy to focus on reduction of trauma. And in those trials, I had the privilege of working with our providers on a week-to-week basis, the supervisors that we had trained, talking about the cases that they were seeing, clients who were faced with violence, grief and loss, illness. And one common challenge that often came out of our calls was that the providers felt like they had skills to treat one problem, one issue, but not the skills to treat all of the different problems that their families were faced with. Problems like suicide, substance use, depression. And so most of the providers we worked with felt helpless because they did not have community resources or other options for referral for clients who had multiple problems. And let's face it, comorbidity is the norm in the field. As a clinician, I've rarely seen or heard of an individual who has just one problem. What we see are individuals in populations with worries, fears, anxieties, trauma responses, relationship problems, grief and sadness. And yet, despite this comorbidity, the current approach to providing services is a siloed approach. So what we see is really focal treatments that focus on one problem and not the comprehensive problems that families and individuals are faced with. And as a team, we started to think about, is this really the best we can do? What happens with the siloed approach is that to help a population heal, a population which we know will have comorbidities, we would have to train, roll out, and implement a large number of mental health and psychosocial programs to address all of the needs. This is challenging at best, often impossible, and definitely costly and unsustainable. One solution to the silo-busting approach, within our field of mental, behavioral, and emotional health is CETA, or the Common Elements Treatment Approach. It's built as a modular and flexible program that has the ability to treat multiple problems, not just one or two, but a wide range, including depression, trauma, violence, aggression, substance use, externalizing problems in youth, parenting, relationship problems, and hopefully soon CBT for psychosis. Research has also shown now through multiple randomized control trials that lay providers can deliver this with adherence and flexibility to address comorbidity. And by lay providers, I'm talking about non-paraprofessionals, non-professionals with a grade 4 education level. So let's take a closer look at CETA. If you look at these elements on the screen, you can see that they don't look unfamiliar. These should be names of components that would look familiar to you. And CETA is not a new treatment. It's made up of existing cognitive behavioral therapy elements that have a wealth of data behind them. What is different with CETA is that we train lay providers to pick and choose the elements they need based on the child, youth, or family that's in front of them. So you might have a youth that comes in and may have mild symptoms that might only need 2 or 3 elements. You may have another family come in with multiple comorbidities, and you may need 5 or 7 different elements. And given its design and flexibility, you can pull out just 1 or 2 elements if needed to supplement a program that you're already running. So there's a lot of information on this slide, but I wanted to highlight some of the evidence behind CETA. We've run multiple randomized control trials, as I said, and I really just want to highlight here that you can see that across many different types of settings, across many different age groups, we have pretty large effect sizes for many different types of outcomes. So again, depression, post-traumatic stress disorder, alcohol use, violence, severity and frequency of violence in the home. And again, all of these studies really looked at the use of lay providers to deliver these treatments. One of the studies that isn't on here that I did want to highlight is a trial that we recently completed in Zambia, which will be published, it's in press currently, where we were working within HIV clinics, and HIV clinic providers were trained in CETA and a short version of CETA for substance use. And in that study, we had pretty large effect sizes in reductions of alcohol for clients who were HIV positive in care. We also have several trials currently ongoing, one in South Africa that's also looking at HIV outcomes as the primary outcome. If you want more information on our trials, you can also visit cetaglobal.org. We have all of our trials, all of our papers there and easily accessible for you. So if you want more information on that. I also wanted to highlight that we are currently pioneering the integration of mental and behavioral health into HIV services. So in Zambia, working with CDC and the Center for Infectious Disease Research Zambia, we've been able to roll out nationally CETA in the HIV care centers. In Namibia, we are doing the same. And then in South Africa, we have 1 trial, but we currently in those 3 countries have 100 HIV clinic staff trained in CETA, 29 HIV centers implementing CETA, and we've been able to adapt CETA to really focus on improving adherence and retention. So I wanted to talk a little bit about the flexibility of the SETA approach. This is a common mental health and psychosocial triangle. So we see here at the bottom, kind of the primary level of care, so prevention care, all the way up to the top level of specialized care. And we really see that SETA can run, because of its modular and flexible approach, can really run through the triangle. So you could offer a one-off session as prevention on the bottom level, all the way up to full SETA in the top level that can really offer specialized care for people with moderate to more severe symptoms. So just to take a look at how this works as a system of care, with SETA, you can offer one-off sessions using evidence-based components and skills to identify and refer children for higher level care. So as an example, in Zambia, as I said, we created a SETA expert, so screening, brief intervention, and referral to treatment. It's a one-off session that lasts 20 minutes, and care providers were trained in it as a way to teach coping skills to prevent substance use in people who have HIV, as well as to identify and refer people who have more moderate and severe symptoms to full SETA trained providers. Again, because the SETA system of care is so flexible, you can pick and choose what will fit best within your current programming. And that could be the lower level, one-off prevention sessions, all the way up to having providers trained in full SETA. And one provider could do both, or you could have different people doing the different roles. So just to end and talk a little bit about the process of training and implementation, we use what's called an apprenticeship model of training. We know in the literature that one-off trainings are just simply not effective in learning these types of skills. And so we start with a live training with providers, but the real learning happens over time with local supervisors through practice groups, and then as they see cases for the first time. And that ongoing supervision occurs, we train to competency. So what that means is basically once a provider is able to show us that they're adhering to the model, that they've seen a number of different cases, that they're able to then practice without our technical support from our end, just with the local supervision structure. And training to competency, the training period really varies. And that kind of makes sense, right? If you think about learning any new skill, like playing soccer, the time you spend doing that skill, practicing that skill, results in faster uptake. So the more time you spend practicing SETA in the beginning and implementing the skills, the faster you'll be competent in them. And so again, there's a lot of flexibility, and it depends on which part of the SETA approach a provider is learning. And just finally, to speak about the delivery of SETA. So again, we really wanted to focus on the use of lay providers. And that's, again, people with grade 4 education. We know in a lot of the low and middle income countries where we work, there aren't mental health professionals or paraprofessionals. So we really want to expand access to care. And so the key, I think, that we've found over time is finding providers that have the time to do this and the interest. They really want to help their community in this sort of way. And those make the best providers to deliver SETA. SETA can be delivered in group format, in individual format. It can be up from 1 session up to 12 sessions, depending on the need of the client. And the session time can really range, again, depending on the needs of the client. The key, again, is just oversight by local supervision and while a counselor reaches competency. So with that, I will end there. And again, just to say that there's a lot of information, videos, all of our publications on cetaglobal.org if you want more information. Thanks.
Thank you, Stephanie, for that nice presentation and family. So we'll head over to question and answer session. We shall start with the first question. I think I'll go this to Dr. Makoko. The first question says, is it difficult to secure antiretroviral drugs for children who live in the street? On the street, what do you recommend? Karibu, Dr. Charles.
Yes, thank you for the question. And yes, there was a challenge to secure ARVs for children and youth working and living in the streets. However, we are working closely with clinical implementing partners to be able to support the beneficiary by making sure that they provide the ARV to the beneficiary or through our drop-in centers, so that the beneficiary can be able to access those ARV through the drop-in centers that are supported through RCA. So yes, we had a challenge, but we are working closely with clinical IPs to make sure that they provide the ARV for our beneficiaries to be able to access them. So currently, with that model, our beneficiaries are able to access the services timely. Thank you.
Thank you. We'll go for the second question. Given most of the children and youth living and working in the street are constantly moving from one city to another, what are the strategies you're using to improve their ARV uptake and adherence among the full-time children on the street? Is there anyhow that you're supporting them with storage facilities? I think this relates to the first question as well. Welcome, Dr. Makoko, for response on that.
Okay, thank you. Yes, we provide the storage services as I had outlined in the first in my response to the first question, but also we also support the beneficiaries through the facilities that they visit. Currently, it is possible to receive ARV at any facility, provided that the beneficiary has been enrolled in any of the facility that he or she was first identified. Through the same unique CTC ID, the beneficiary can be provided the ARVs at any of the facility that he or she will be should find himself or herself at any time. So the unique ID that is provided through the National AIDS Control Program support can be used at any facility, and through this, the beneficiary can access the ARV at any facility. Yes. Thank you.
Okay, thank you, Dr. Makoko. Yeah, we'll go for the third question, which is related. I think you okay, for the third question, which is also related to question number 5. I think I'll just combine them and have one question. It says the increase in HIV prevalence for children and youth living on the street for a long time is shocking. What does this tell us about the need to ensure that street outreach is prioritized in HIV programming? And also question number 5, has gone more into knowing, would appreciate to know the factors leading to higher number of HIV infection in the mining industry as compared to other areas. So I think this is two related. Maybe Dr. Makoko, if you could respond to these two.
Okay, thank you. Thank you for the questions. Yes, the numbers are alarming, as you have shared, and that is why are also in the forefront of ensuring that any guideline that is being developed should have should be comprehensive. There are services that are related to children and youth living and working the street that are so this is a place or an area that we constantly make sure that the voices of these beneficiaries that we are serving are included in any guidance that is provided by the facility. So as I said, currently with the because beneficiaries are able to receive services at any of the facilities just with the CTC ID that they are provided. It enables them to access these services timely and without any interruption in treatment when they're not in their residential areas. The question around mining, why the prevalence is high, it relates to how the beneficiaries or the workplace that these beneficiaries are involved. So in mining areas, these are places where they lack basic health services and also access to things such as condom, which can be used or to prevent HIV services. So mining areas in Tanzania and in many middle-income countries are really not structured to be able to provide the services to various categories of people. So with that challenging access of services, the children and youth being vulnerable, and as well as those children who find themselves in those areas have a higher risk of having HIV, a higher risk of contacting HIV from the sexual practices around if they have any sexual practices in these areas. So this is a special population that we also have a different intervention that or support the beneficiaries who are in the mining areas. So today I will not go into details on how we support the mining beneficiaries, but it's also one part of the supported beneficiary of Kizazi Kipya with another tailored approach to those beneficiaries. Thank you.
Thank you, Makoko. Welcome, Stefan. Adding.
Sure, I'd be happy to. I would say that, as well as, I completely agree with what Dr. Charles Makoko is saying. And I think that when we think about time on the street and the children living in the mining areas, that it really is time for and risk of exposure, right? The more time you spend in these environments, the more risk you have of exposure to very stressful and challenging situations. And that those sorts of situations then put you in a place where you're more likely to, again, have some risky behaviors yourself. So risky sexual behaviors, substance use, which in turn then puts you at risk for HIV infection or non-adherence to treatment if you are HIV positive, as well as risk for exposing others. So I do think that looking at kind of the stressful environments and situations that children and youth are living in really compounds this factor.
Yeah.
Thank you.
Thank you, Stephanie. Makoko, another question, I think I'll first post to Stephanie. How do we ensure effective coordination between facilities and obviously platform to ensure continuum of care? I think given the context of how you've been implementing CETA, how can we ensure we are coordinating these services between the facilities and the children, looking into context of their mental health? Maybe how can we work around all this one?
Sure. So obviously, coordination is key to ensure that children receive a continuum of care. And I think that in Zambia, we've had success with working with technical groups and making sure that the Ministry of Health has a technical group that in Zambia is working with all of these different partners and bringing them together to have conversations to make sure that these services are integrated well and that there are no gaps. And so it does take a fair amount of work to ensure that there's a continuum of care, and really requires all of the players who are involved in the different care systems to work together. And that can be challenging at times, but I think that it's really important to make sure that children receive the best quality care with no gaps.
Okay, thank you, Stefan. Dr. Mokoko?
Okay, thank you. To add to that, we also have been working with clinical implementing partners as also and also service provider at facility level. Under the Kizazi Kipya project, we have been having a facility and community framework for working with all these three partners, whereby we have bi-weekly meetings where we come together and discuss issues around the beneficiaries that we serve, in case there are beneficiaries who are have missed their appointment or have high viral load. We do case management visits, case conferencing, to make sure that we all chip in to ensuring that these beneficiaries receive the appropriate services. So going forward, we are also looking into having memorandum of understanding rather than just having a framework, but that rather a more formal MOU to bind these partners in ensuring that the services provided to the beneficiaries cuts across and support them across the continuum of care. Thank you.
Okay, thank you, Dr. Mokoko and Stephanie. We'll go to another question, of which I'll post this to Dr. Mokoko. I think from the presentation, we've seen there are high numbers of children living with HIV in OVC general, rather than those reported from children who are living and working in the street. Maybe Dr. Mokoko, can you tell us a response to that?
Okay, thank you. So OVC general, as in Kizazi Kipya, OVC general has beneficiaries who are identified through facilities, care and treatment clinics. So this makes a larger proportion of these beneficiaries, and this number affects the overall number of the beneficiaries that are supported by Kizazi Kipya project. In the presentation I made, we also have efforts that we are doing to enroll beneficiaries, children and youth living and working in the street. But as you know, this is a more marginalized group, and making sure that we identify and enroll them. We have different strategies that I shared using the peers who are in the project to identify them and enroll them. But it is easier, and we have more of children who are HIV positive at CTC who are supported by Kizazi Kipya, and that number affects the general number that is being supported by Kizazi Kipya project. But efforts are being made to make sure that more of the street children are identified and enrolled into the project so that they can receive the support that they require. Thank you.
Okay, thank you, Dr. Mokoko. We have another question, which I'll post this to Stephanie. Yeah, given that we know there's incidence of stigma in a community, especially around HIV, and this is one of the obstacles that cause children who are living with HIV feel to have a stake in their community. So maybe if you could give us an experience from your project, how was your project able to eradicate that kind of barriers, especially taking into context people who are living with HIV or children who are living with HIV?
Sure. Yeah, stigma is definitely a large problem and an obstacle to receiving care. I would say that the CETA approach really looks at tackling this in a number of different ways, knowing that it's a barrier to treatment. First of all, when we think about CETA as a system of care, those initial sessions can be really done with any population, a general population. It can be framed in a way where we're really just building coping for a group of youth or children, and really focused on then assessing each child individually, and then in conversations, really looking at what their barriers to care are. And then within CETA, the components that we use sometimes to tackle stigma are really things like cognitive coping. So when we can't change our situation around us, how do we change how we think about a situation to have a better outcome for ourselves? We also use cognitive restructuring. So when we think about kind of core beliefs and issues within a community, how do we change those to be more helpful to receiving care? And we really do look at each child's individual barriers and look at problem solving. So how do we work around those barriers to treatment and have other skills that we may bring in to help the child tackle those reasons that they're not getting care?
Thank you, Stephanie. I think just an additional question. As you spoken during the presentation that you could use laypersons or lay providers in delivery of CETA. So maybe how do you ensure that there is continued commitment of the laypersons in delivering the program?
Yeah. It's a great question. We've run multiple studies and multiple projects, and we don't always have providers that stay. We've had lots of lessons learned over the years. I think that one of the key things that we find is, first of all, just finding providers that really want to do this, right? That are intrinsically motivated and interested in helping their community in this way, as well as finding providers that have the time. I think one of the barriers for people staying committed to this is sometimes working in HIV clinics or other programs, people are pulled in many different directions. And if this is just added on top of everything else that they have to do, it's really hard to complete all of their job tasks, right? And so really looking at how do you shift things off of people's plate, who within your program makes the most sense to do this kind of work, and really, again, looking at it as a specialized skill. We do know in some of our programs, they've been given a different title, or they've been given, lay providers have been given a particular top up to their stipends. So it really depends on the programs, but we do have programs where that doesn't happen. And we have providers that were selected because they really wanted to do this, and we were able to roll it out successfully, again, with shifting some other tasks like client visits or filing or other tasks off of their plate so that they have the time to do this work.
Thank you, Stephanie, and for your responses, and also Dr. Makoka. Thank you very much. So from our two presentation, I think as we have seen that, and from the experience we've been having working under USAID Kizazikipia, working with early children, ECPAF, and implementation of the project to reach most vulnerable children. We've seen that it's very important and to be able to integrate HIV services to these children. As we know, some of these, especially as we've been seeing, especially in the context of children who are living and working in the street, and also those living in the mine areas, it might be a little bit tough at times to be able to reach them or to ensure that they have continued uptake of services. So there's a need to make sure that we have interventions that are able and are tailored to be able to meet their needs, and also to provide for the challenges that they're facing. So I'd like to thank you, Stephanie, for your input from what you've shared with us as you've been working with SETA, and also Dr. Makoko, for input from what Kizazikipi has been doing in children are living and working in the street and also in the mining areas, and also for the questions from participants that have been shared. I'd like to thank you all for being able to participate in this. I'd like to welcome Mary to take over. Thank you. Karibu, Mary.
Thank you, Edward, and thank you, Stephanie and Dr. Charles, for sharing with us the great work that you've been doing in supporting marginalized group to access HIV services and also for adherence. And thank you for our audience for being part of this webinar and also for your questions. And we've not been able to answer all the questions, but feel free to reach out, to email us. Stephanie email address is there. Dr. Charles, if you need Dr. Charles' email address, we can provide, and also Railway Children. So thank you so much for being part of this webinar. And we have another webinar coming up at 4 o'clock, and I hope some of you will join us for the next webinar. So thank you very much, everyone. Bye-bye.